Good afternoon. Good afternoon, Monday afternoon at about 2 o'clock. Let me give you a couple things that I want you to be aware of. I want you to check your emails and things on Canvas regularly because I'm going to try, keyword try, to get you at least 2 or 3 videos per week. Okay, at least 2, minimum of 2. If after watching the video, you take notes again because you're going to turn in that what? That folder to me at the end of the semester here, sometime at the end. I'm going to try to work that out, how to do that. But anyways, I'm going to do 2 to 3 of these per week. If you see something in the video, maybe you write it down on the side. Maybe part of this folder includes what? Your notes, a 3-page type paper, okay? The syllabus that I gave you at the beginning of the semester. Don't worry, I have plenty of them hanging around, so if you miss one of those, don't worry about it. Okay, but if you don't understand something, make a note. Give me a call because I want you to understand it then rather than, you know, just before your final exam and you're really not understanding it. Give me a call. I don't mind talking to you. Okay, so today we're going to do several things. First thing I want to talk about is running the EKG. So remember, the machine is called an electrocardiograph. Okay, that's the machine, graph, G-R-A-P-H. It prints out a picture. The picture is an electrocardiogram. Okay, and then when we run the EKG, we're actually running it. Patient's connected up. We're doing electrocardiography. Ography is taking the picture. Gram is the picture. Graph is the machine. But don't use these words around, the doctor's office, because if you go in and go, where's the electrocardiograph? They get a little confused sometimes. So do I. So just say, where's the EKG machine? All right, but at least you know some of the technical terms. All right, you need to explain this to the patient before you do it. You need to explain that, they see us putting wires on them and then plugging it into a wall. Probably an older person, maybe like myself, all right. Oh, no. We're not going to electrocute you. We're just taking a picture. It's not going to hurt. We want you to lie still. Are you warm? Because if you're not, we want to get them a warm blanket. Okay. We want to make sure that we're not pulling on the leads. This type of thing. We want to standardize the machine before we run it. And by that, there's a little switches on the machine. One of it is the run speed. In other words, how fast the paper is coming out of the machine, like pulling on a toilet paper. How fast that paper is coming out of the machine. We want it normally at 25 millimeters per second. That's normal run speed. Okay? And there's a switch on the machine that shows that. We want the height and depth of waves, the amplitude or voltage is what we're measuring for height and depth. We want that to go up, goes up like a Lincoln top hat, comes over and drops down. We want that at 10 millimeters. Okay, 10 millimeters. And so once again, see if I can hold this up, it looks like a Lincoln top hat. So when we standardize it for amplitude or voltage is vertical. We want it to come up 10 millimeters, which is 2 blocks, big blocks high, come over and drop back down to baseline again. We want the baseline or the isoelectric line running straight down the center of the paper. We don't run it running up at the top or running down at the bottom. We run it running straight down the center of the paper. Okay? So we want to make sure that those are set before we run it. Otherwise, we're going to end up with something we have to throw in the trash can and start over again. All right. I'm going to go over a couple of arrhythmias today. Okay? And I'm not going to tell you every single thing about the arrhythmia, but one thing I want you to do is be able to explain it to me in a word picture. In other words, and I'll go over this again later today in this video, we talk about atrial fibrillation, which is the most predominant arrhythmia of all the arrhythmias, AFib. You see it all the time on TV. You know, we want you to explain that. I want you to explain that very simply. In case you go in for an interview and somebody goes, hey, explain atrial fib to me. Okay, well, I can recognize it, but I can't explain it. No, you should be able to explain it. Okay. We have no P waves. No P waves. Multiple ectopic atrial spikes. Like somebody's got real bad shakes, okay, for some reason, you know. We want you to say, hey, it looks like this, no P waves, okay. Multiple ectopic atrial spikes called F waves or fibrillatory waves. Okay. The ventricular rhythm, this is going to sound weird, is irregularly irregular. It's all over the place. You can't space it out with your calipers. It doesn't march out. Okay. We want you to tell us why it may be there, at least one thing. Don't memorize paragraphs here. One thing of why it may be irregular. Okay. Irregularly irregular. So I don't want you memorizing entire paragraphs, but at least explain it to me. One girl one time from the nursing program, I came up and she was in the nursing program, and I said, hey, explain atrial fib. She goes, okay. Let's see. The top chambers, they're going like this. No. The bottom chambers are going like this. No. The top chambers and the bottom chambers are going like this. And I'm going, oh boy. I said, hey, listen, with all due respect, don't say that to your instructor or they'll shoot you. Okay? You have to get this down a little bit more. Word pictures, simple word pictures. Okay, on every arrhythmia that's out there. Okay? And I want you to tell me one reason they may have that. Just one. I mean, if you want to come up with two, God bless you. That's good. Okay? Notice this is my stable diet, little Coca-Cola. It's not a Bud Light, but I may wish it was. Okay. So I'm looking on page 87, and it's the first dysrhythmia I will talk about today. Wandering atrial pacemaker. What? Okay. If you look up top of page 87, what do you see that may be different? Okay, I noticed something right away. The ST segment is depressed. That's not normal. The ST segment, right after the QRS, right after the J point, remember the J point is where remember the S wave comes up? Just before the S wave levels out, right there where it levels out is the J point. So the ST segment between the end of the S wave and the beginning of the T wave should be right at the isoelectric line, okay, or baseline. And remember how to get the baseline, right? Look right at the P wave. At the end of the P wave, there is a little 1/10 second pause. Bring your paper up or your ruler right at that pause, okay? 1/10 second pause and put your level right on that piece of paper, something like that, right up at the bottom of it. It should be, that's the ST segment, okay, or that's the baseline. Now, this ST segment's depressed. The ST segment is a very darn important piece of diagnostic material. We don't want to be above the baseline. Okay, that's elevated ST segment. Or below the baseline, we want it right on the baseline. So this ST segment, whether somebody thinks so or not, is depressed. It's below the baseline. Okay. You can see that just by looking at the 1 10-second pause, which doesn't show up really well on this strip, but I'm at page 87 right at the top, figure 7.3. Okay, the other thing that I noticed, hope you noticed too, is that all the P waves look different. What does that tell you? Well, it tells me right away that the pacemaker is coming from different sites. It's all over the place. So that's why they say the pacemaker is wandering. It's going from the SA node to an atrial ectopic focus to another atrial ectopic focus. And each atrial ectopic focus is going to print a different P wave out. The P waves are going to be different in size, shape, and direction. Okay? These are varying, which tells you that the pacemaker is wandering. Okay? The rhythm could be regular or irregular. Don't think that's hard to figure out because it doesn't what? When you take your calipers, it doesn't march out. And the rhythm should march out. P to P, R to R should march out. And P to P, R to R should be exactly the same if it were a what? A normal sinus rhythm. Okay? The rate of WAP should be somewhere between 60 to 100, but it may be slow, less than 60. Okay? The P waves vary again in size, shape, and direction. The PR is usually normal duration, but it may be abnormal. What's normal? The beginning of the P to the beginning of the R, or the beginning of the Q, whatever's up there. Okay? So the PR is usually normal, 0.12 to 0.20. But it could be abnormal because it's changing pacemaker location all over the place. And that could give you an abnormal PR. So it could be greater than 0.12. Okay? Or it could be normal. The QRS is normal, 0.10 or less, and QRS. Let's take a look at this. It doesn't look like it's normal. You can tell right away that the rate, okay, is varying. And the R to R, you can see that. Hopefully you can see that. If I take calipers, you can do that right now. Take your calipers out, go R to R. Are they the same? No, they don't march out. Go P to P. Do they march out? No, because the pacemaker varies from site to site. Okay. So, give me 1 second here. Looking at something, and I want to make sure I give you everything here that I should be giving you. Okay, now sometimes wandering atrial pacemaker, and I want you to look this up, look up the word vagal, V-A-G-A-L. Because of vagal effect on the SA node, okay, the result of this could be slowing of the sinus rate, allowing other pacemaker sites the opportunity to take over. Remember I talked to you about something called overdrive suppression? That means whatever pacemaker drives the fastest, such a word as fastest, okay, whatever pacemaker drives the fastest is in charge. The SA node is between what? 60 to 100. But, okay, if the SA node fails, another pacemaker can take over because the SA node has pacemakers that are redundant, redundancy pacemakers, okay, that can take over. So remember that atrial pacemakers can take over between 60 to 80, If one pacemaker fails, the other can take over, and that's atrial. Junctional can take over from 40 to 60, and ventricular can take over between 20 to 40. WAP is seen in very young people, okay, or very old. I don't know anybody that's old besides me, but anyways, very old. Wandering atrial pacemaker can be a result of normal sleep cycles. It can be caused by administration of DIG, okay, digitalis. WAP isn't really clinically significant, and treatment is not indicated, okay, usually. But if the heart rate is slow or medication should be reviewed or discontinued, that may be a result of WAP, okay, wandering atrial pacemaker. Wandering atrial pacemaker is sometimes associated with rates greater than 100. Once again, the rhythm of WAP is multifocal, okay? And we can also have something called multifocal atrial tachycardia. Okay? And multifocal atrial tachycardia is nothing more than a WAP at a rate greater than 100. Okay? You take a look at the bottom of page 87. Multifocal atrial tachycardia. The rhythm's irregular. The rate on this one is 140 or greater. The P waves vary in size, shape, and direction. The PR is normal, somewhere between 0.12 to 0.20. I know it says 0.08, but that's normal too. The QRS is normal, 0.10 or less. Okay, this says 0.04 to 0.08, but it's still normal. Okay. Wandering atrial pacemaker is also associated with lung diseases like COPD, chronic obstructive pulmonary disease. All right, so we'll move on. I'm over on page 88, and then on page 88 it says premature atrial contraction. Well, it pretty much spells it out to you. An atrial focus prematurely fires. Now, how do you know that? Well, if you're looking at a strep and all the P waves march out and all the R waves march out, and the R waves and P waves are exactly the same, and then all of a sudden you're going down the strip, take a look at page 89. You're going down, and all of a sudden you have something that appears early. So what is a premature atrial contraction? Well, premature is like a premature baby. It comes early, right? Shouldn't be there, but it comes early. So page 89, over here, I've got a rhythm, a sinus rhythm, and then all of a sudden a PAC shows up, premature atrial contraction. How do I know that? Because by measuring this out, right, with calipers, this whole beat comes early. And the P wave is different in size, shape, and direction than the one next to it or the one over, a couple of beats down. It's different. So it's a premature atrial contraction. If it were inverted, I would say, okay, it's a premature junctional contraction. Okay. Well, premature atrial contraction, okay, comes early. We know that. The rhythm is usually regular, but it can be irregular with the PAC. The rate is that of the underlying rhythm. The P wave is associated with the PAC, premature. The PR is usually normal, but not measurable if it's hidden in the T wave. In other words, if the P and the T get really close together, they can cause something called the TP wave, where the P is hidden in the T. The QRS is usually normal. Okay? Now, why did the P wave or the atrial beat fire? Well, because the focus may have been irritable. Something irritated it. And it came along and it made this, over on page 89, this P wave fire early. So an irritable focus sends out a premature atrial contraction. Down at the bottom of page 88, we have sinus bradycardia with a premature atrial contraction. Well, how do I know it's braid? Well, one of the first things you do is tell me, is the rhythm regular or irregular? Well, if I look at this, it's irregular. But this brings me to a point. Why is it irregular? Because if you look at the two center beats right there in the center of the strip, that's a PAC. How do I know? It comes early. Should come later, but it comes early. Giving me a premature atrial contraction. Over on page 89, I have normal sinus rhythm with a PAC, premature atrial contraction. Okay, now notice the bottom figure, figure 7-8. And notice that it says PAC. Once again, premature atrial contraction. Well, that's kind of a funny looking figure there because I don't see the P wave, so where is it? Sometimes if the P waves and the T waves get too close together, they coalesce into one wave called a TP wave. So this is one of them. Because the P and the T got too close together, we can call this a PAC. But that wave just before the QRS is a TP wave. I'm looking, stay with me. Okay, now we get into something called non-conducted PAC. You'll see that over on page 93. And right in that center strip, can you see a P wave? Yeah, but what? What's wrong with this? It's not followed by a QRS. Okay, and I'm measuring this from the left. 1, 2, 3 beats from the left of the strip. There's a P wave, but no QRS. So if there's a P wave with no QRS, it is called a non-conducted PAC. Why do we use that AC along with it? Because it should contain, okay, after the P wave, the QRS. Okay, but it's a non-conducted premature atrial contraction. Non-conducted meaning you don't see the QRS, everything with it. You're down at the very bottom of page 93, I see a normal sinus rhythm, again, with the non-conducted PAC. And then over on page 95, I see paroxysmal. Paroxysmal. If you can say that to yourself. Paroxysmal means sudden. It's sometimes abbreviated PAT, paroxysmal atrial tachycardia. So what does that mean? A sudden tachycardia. Okay. Now, top page 95, how do I know it's an atrial tach? Because once again, the P and the T have coalesced into one. Okay. And the rate, notice the rate here, 188. The P waves are what? Hidden. Where? In the T wave. That's a TP wave. Okay. So the PR is not measurable because I don't know how to get the P wave out of that coalescing with the P wave. So it's not measurable PR. The QRS is normal, 0.04 to 0.08. Remember, 0.10 or less is normal. Now, atrial tach can occur with people that are healthy. They have healthy hearts. Atrial tach, showed you that a little bit earlier. It's most common with arrhythmias in children. But you drink alcohol, right? Just throwing that in. Got to be 5 o'clock somewhere. Drink a little alcohol. And you have some caffeine. You have some tobacco. You have some anxiety, fatigue, electrolyte imbalances. Okay, you can have atrial tach. During atrial tach, sometimes you feel palpitation. Okay. Once again, I just want one of these. So you tell me atrial tach, just tell me, hey, man, you're drinking alcohol a lot, you're smoking. Okay, it's the caffeine, it's the alcohol that's causing a little tachycardia. Okay, now notice over on page 97, I have atrial flutter. Now this is a good one. Notice the P waves called F waves. Now you go, well, didn't you mention F waves a moment ago when you said fib? Yeah, those are called F waves too, all that little shaking. Okay, you can't see the P wave, but you see a little shaking, called F waves or fibrillatory waves. Well, we got one more F wave. But these F waves are called flutter waves. And they're probably at a speed of 250 to 350. And now don't go, well, my book says something. They all say something a little bit different. So the F waves, the flutter waves are between 250 to 350. I want you to see how they look, back to back. Okay, back to back. And the biggest thing with the strip is you flip it upside down, and the F waves look sawtooth. They look like the teeth of a saw, which means you have atrial flutter. Okay. Now, atrial flutter, the rhythm can be regular or it can be irregular. Notice here, initially looks pretty regular. Why? Because normally I see like 4 F waves prior to every QRS. Well, if I go 4 to 1, 4 to 1, 4 to 1, then the rhythm is what? It's regular. But if the P waves or the F waves in this case vary, like from 4 to 1 to 2 to 1 to 3 to 1, then the rhythm is what? It's irregular. So the rhythm can be regular or irregular. The atrial rate, somewhere between 250 to 350. The P waves are going to look V-shaped, sawtooth. The PR is not going to be measurable in this. The QRS is usually normal, 0.10 or less. Now I'm going to continue with atrial flutter. P wave, sawtooth. PR not measurable. QRS 0.10 or less. All right, what else do I want to tell you here about atrial flutter? And by the way, I'm over on page 99. You want to take a look at that in your book. Okay, so I'm looking at the bottom of page 99 over on the left, last sentence. Typically originates in the right atrium. Most often involves a large reentry circuit that travels around the area of the tricuspid valve. Okay? See what else I can give you here really quick. And if I pause, I haven't gone to sleep. I'm just looking at things that I want to give you. Okay, it's rarely seen in patients with normal heartbeat. Or it's rarely seen in patients with heart failure. Decreased blood flow to the heart related to ischemia, you can get it. Cardiomyopathy, Abnormality of valves of the heart. You can get in women a lot. The valves of the bicuspid, also called the mitral valve, trays up like you're blowing air under a parachute. Okay, and when the left ventricle, hope I said the mitral valve on the left side, when the left ventricle contracts, the mitral valve ought to shut. Instead, it comes up like you blew air under a parachute. Okay, and tugs on little chordae tendineae. And they get what's called MVP. Sorry, we're not talking about football here, but mitral valve prolapse with this. Okay, so if they have abnormalities of the heart valve, this can also cause atrial flutter. Now, I want to go over to atrial fib. Okay. And I'm over on page 100 and 101. Notice 7.26, strip, figure 7.26, bottom of the page 100. And they say this is atrial fib controlled. Listen, if atrial fib is below 100 beats per minute, 100 or below, it's called controlled atrial fib. If it's above 100, it's called uncontrolled atrial fib. What's the main problem here with atrial fib? The atrium are not contracting. They're fibrillating. They're shaking like this. There's no contraction. And why is that? Because multiple ectopic foci, ectopic, occurring in a place other than normal. Atrial ectopic foci, a bunch of them, are firing together like this. And it's been likened to what is called a bag of worms. There's only two areas in the heart that have the word fibrillation. Atrial fib and ventricular fib, have fibrillation. In atrial fib, multiple ectopic atrial foci are all firing at once, so there's no coordinated atrial contraction. So you know what that means? You've lost atrial kick. Now, part of the blood from the atrium go to the ventricles. Remember, the atrium are on top, ventricles on the bottom, four chambers of the heart, atrium on top, ventricles on the bottom. Part of the blood from the atrium go to the ventricles by gravity. The last part of the blood going to the ventricles is because the atrium have a coordinated contraction called atrial kick. Well, here there is no coordinated contraction. So how's blood getting from the atrium to the ventricles? By gravity. It's dripping through the valves down into the ventricles. No coordinated contraction, which means that you can lose 30% or greater of your cardiac output. 30% or greater. Because you've lost atrial kick, contraction. Last part of what the atrium do is they contract. Now look at the figure 7.26 at the bottom of page 100. First of all, the rhythm is irregular. It's always irregular. Why? Because the pacemaker of the heart, normally the SA node, here there is no pacemaker. They're all shaking. And eventually, remember, the pacemaker has to go from the SA node to the AB node, to the bundle of His, to the right and left bundle branches, to the Purkinje fibers. Has to travel there. Well, here, because the pacemakers are literally shaking and only an occasional pacemaker is conducting, occasional, to the ventricles, then the ventricular rhythm is, ready, irregularly irregular. So what do you see here? You see a wavy line, okay, in place of the P waves, wavy. And that is, the wavy line is fibrillatory waves, called F waves, which looks like it's just shaking. Now, sometimes I'm going to tell you this, the wavy line looks, you hardly see spikes, multiple ectopic atrial spikes, okay? Like, if I can do it here, like this, atrial spikes, okay? Called F waves, fibrillatory waves. But sometimes those spikes are like just a wavy line, okay? Like you took a Sharpie and went over the line. So you don't see the spikes very much. Remember, the spikes are called F waves or fibrillatory waves. Now, the big thing with this, and you hear this on television all the time, this is one of the big commercials. I have atrial fib. So I do. I was going to say I didn't, but I do. You need to be on some type of I'm getting there, it's getting late in the day, some type of blood thinner. Now, in reality, I'm going to tell you this, there's no such thing as a blood thinner. You know, when people say it, just say it too. But you don't dump stuff in the blood and thin it out, kind of like we want to paint all the walls here in my living room, you know, and we're running out of paint, so we thin it out with a little bit of water. No, there's no such thing as a blood thinner. That's not how warfarin, okay, and other, I go to the word thinner again, works. But you can call it a blood thinner because if you call it anything different, they're going to, you know, look at you like you're crazy. So go ahead and call it a blood thinner. But we want to put them on some kind of a blood thinner, like warfarin. And the reason we do that is because blood is sitting still in the atrium, which when blood sits still until it drips through the atrioventricular valves, the tricuspid on the right, bicuspid or mitral on the left, it's sitting still, it can clot. And if you throw a clot, all kinds of bad things can happen. You could die because you throw a clot. That clot can go to your lungs. It can go to your brain. So you want to be on a blood thinner. Okay? That's one of the biggest things that we put people on if they're an atrial fib. The other thing we may put them on is called a beta blocker. Now, I want you to understand this, and I'll mention it a little bit more later. But drugs are kind of like keys. Okay? Got a key in your pocket, you all know what a key looks like. Okay? So drugs are like a key. They enter a lock, which is called the cell surface receptor site. And when they enter that lock, they block the lock or they turn the key and cause something to happen. Well, one of the heart drugs are called beta blockers because in the heart there is a beta 1 cell surface receptor site, a lock. And because I have atrial fib, I'm on metoprolol. And metoprolol is a drug, it's a beta blocker. And metoprolol blocks beta 1 receptor sites. Why? Because if any stimulant gets in a beta 1 receptor site, it causes the heart to have arrhythmias. Here's a stimulant. Okay, this is, you guys can tell me later. I should be drinking water, but it's a stimulant. Okay? If it stimulates this, okay, because I have atrial fib, then atrial fib gets worse. So I take 25 milligrams of metoprolol QD per day, QD every day. And I split it into half a dose in the morning and half a dose of the evening. And that kind of helps prevent stimulants. Okay. Locking in a beta-1 receptor site, metoprolol is a key, beta-1 receptor site is a lock, from aggravating the atrial fib more. So atrial fib can be a big deal. Now, sometimes atrial fib is also atrial flutter. So you can have fib flutter. Well, that's something to say. Okay, so if you go over to 101, you see atrial flutter, fib flutter. Okay, so part of it's fib. Okay, in the first couple of beats, I'm noticing fib. Then notice a flutter after the third beat. Yeah, the back-to-back, okay, waves called F waves or flutter waves. Okay, all right. So sometimes fib and flutter can go together. So the rhythm on atrial fib is irregular. Irregularly irregular. There's no pattern or rhyme to it at all. And there's no atrial rhythm. There's only ventricular rhythm. Okay? But the ventricular rhythm is grossly irregular. Irregularly irregular. The rate, somewhere between 350 and 450. Okay? Some books say 250 to 350. One I like, 250 to 350. No big deal. The P waves, F waves, fibrillatory waves, little spikes, or wavy. Okay, like you took a Sharpie and went over. The PR is not measurable. The QRS is normal, 0.10 or less. All right? Well, that helps you out with that. Let's flip over. And some of these, videos, I'm going to try to make a little shorter. So you can have your Bud Light or margarita time and enjoy it. All right. Now, one of the things I mentioned earlier today, I believe in this tape, I mentioned a block, a sinus block, and right with that I mentioned sinus arrest. Now, sinus block, guys, and sinus arrest has to do with the AV node. So when you say sinus, you're talking about the AV node. And what is the AV node? It's a pacemaker. Okay. So in sinus block and sinus arrest, let's do the block first. It's easy. Let me see if I can coordinate an example here out of your book. So every time you look at a video, have your book with you and have your notes with you, and your notes don't have to look perfect. I'm not asking for that. Okay, and written on paper somewhere. All my notes in nursing, I had notes on McDonald's, French fry, things. I'm going, oh my gosh. If it wasn't for a girl that took good notes in the nursing class, I probably wouldn't be talking to you today. But here it is. Take good notes if you can. And once again, if you have a problem understanding something that's going down, okay, give me a call right after the video or sometime after that. Say, hey, look, or just write it down if it's too late. If you're watching it at midnight or something, write it down. I'll talk to you later. Okay, but call me as soon as you can because it's important to understand this. Okay, so if you're looking at a strip and all of a sudden, say a normal sinus rhythm, all of a sudden you hit a flat line and then the rhythm picks up again. All right, and maybe it's only for a cycle. You hit this flat line, and then the rhythm picks up again. All right, so here it is. That and you using your calipers, those are very important to use. You're going across P to P, okay? And you don't have to pull your calipers in and out. From the left, you're going across R to R. Okay? And all of a sudden you notice this flat line somewhere in the middle of the strip, maybe. Doesn't have to be in the middle, it could be 3/4 of the way down. You're going to go across the flat line with your caliper. And if the rhythm picks up after the flat line, and you don't have to pull your calipers in and out, then it's a sinus block. And here's why. Because the SA node is still firing. It's still firing. It's still giving off impulses. But for, one cycle maybe, you get a block. And you don't see the P wave. You just see a flat line. Okay? But the rhythm picks back up where it should because you're going across calipers. You go, should have picked, it picks up there. Okay? Over to the right, right? Then it's a sinus block. Now, at some time, it may be called a sinus pause. And if you use the word pause rather than block, I don't care. Because the word pause is kind of an encompassing word for sinus block and sinus arrest. Let's pick up that same thing again. Let me see if I'm trying to look here on the rhythm strips in your book. So if you're going across with your caliper, let's just say you're going R to R or P to P, and you hit that line that there's nothing, there's no P wave, there's no QRS. But the rhythm, you're going to go across that with your calipers, the rhythm does not pick up on time. That's a sinus arrest, which means you took out the SA node. Okay, for that small, you may take it out for 2 or 3 beats, okay, 2 or 3 cycles. So the rhythm does not pick up on time. If it picks up on time, it is a sinus block. If it doesn't pick up on time, it's a sinus arrest. Take a look at page 49. It took me a while to get there. Page 49. Notice you've got an NSR, a normal sinus rhythm, or you can call it an RSR, regular sinus rhythm. And you're going through calipers. That's what that little line is. Going across, and notice all the R waves march out. But then you hit a flat line, right? You keep going, but then the rhythm starts again. It starts what? On time. Sinus block. Okay. Now go down to the bottom strip on page 49. And you're starting on the left again, and you're moving over, and then all of a sudden you go across with your calipers, and the rhythm does not pick up on time. That's a sinus arrest. Now, sinus block and sinus arrest are treated exactly the same. And it's really no big deal if you see the line and you don't have time to mess with your calipers. If you call it a sinus pause, nobody's going to be, not knowing what you're talking about. So sinus pause means sinus block or sinus arrest, right? If you take a look at the middle strip, page 49, strip 6-8, going across with your calipers, the rhythm does not pick up on time again. Okay, what is that? It's a sinus arrest. So, you can say sinus pause, and I'll be happy. All right, now, one other thing I want to say to you before we quit today, and that is, how do you look at a strip? You pick up a strip, or you're looking at something, on the machine, I want you to look from left to right. We read an EKG strip by left to right. We don't jump in the middle of it. Okay, I got a sentence. Let's say. Let's use page 49. Let's use figure 6-7. And go into rhythm. So what's the sentence say? Basic, rhythm, regular. Irregular during pause. Okay, I can go for that. Now, how about if I just said this? I came up to you, I tapped you on the shoulder, and I said this. Regular. You'd be going, Mr. White, are you taking medication? Or I go down to rate. 84. What's all that mean? Nothing. Why? Because I'm not reading left to right. I'm not going this way, left to right, right? I'm jumping in the middle of the sentence and telling you something. Why? Because I don't want you to get myopic. I don't want you to jump in the middle of the strip and go, PVC. What's that tell me? Absolutely nothing. Nothing. I don't even know what you're talking about. I know that PVC is a premature ventricular contraction. But what is, I want you to write this in big letters, what is the underlying rhythm? What do we have? Okay. So you need to read from left to right. So in figure 6-7, right? The rhythm is regular. The rate is 84. What am I looking at? I'm looking at a normal sinus rhythm with sinus block. That's reading left to right. Normal sinus rhythm with sinus block. I'm not jumping in the middle of that sentence under rhythm and going regular. What if you had a rhythm and you had a PVC? You come up to me and tap me on the shoulder. PVC doesn't tell me anything. Read from left to right. Take your time. You can read slow. I talked to one guy not too long ago. Oh, my wife got me this. These are my favorites. You want a better grade? Give me one of these. Supposed to be an icy. Now it's a slushy. Oh, that is good. Should be drinking water, but what do I know? All right. Always read from left to right. Take your time. Ran into a guy not too long ago. He told me this. He was an ER tech. Now, I think it still goes this way, and you can call paramedics, and you can ask them. Here, I can find out for you. I was told that if you take basic arrhythmia, if you take EMT1, Emergency Medical Technician 1, and if you take phlebotomy, that you can be an ER tech. So one of the guys did it, applied for a job at the ER, and he told me not too long ago, he said, I said, how's it going? Oh, pretty good. Good. I said, he was in my class, and I said, so you remember your arrhythmias pretty well, right? Short sentence. Should tell you what the arrhythmia is, not a paragraph. So I said, no P waves, irregular ventricular rhythm. What do you have? And so he goes, well, let me tell you this. He said, he's talking to me now. You really don't have to know that. And I said, why? Well, because the doctor interprets it. So you don't really have to know what the arrhythmia is. Guys, I told him nicely. That is ridiculous. That's exactly like the reason you were hired. What if the doctor's busy, especially today, right? What's going on with Corona and everything, yeah? You have to know what you're seeing. What if you put him on the scope and there's more than 6 PVCs per minute, which is pathological? He's throwing multifocal premature ventricular contractions. That's dangerous because that can lead into what? Ventricular fib, VFib. That's dangerous. Doctor ought to know that. Okay, he's busy over here doing something, and you're looking at this over here on a patient You should be able to tell them, doctor, we've got multifocal PVCs, more than 6 per minute or 6 per minute, whatever. Okay? That ought to be a thing that he can either take care of right away, or they'll tell the PA, the physician assistant, hey, go give him this, before he goes into VFib. Yeah. So it is your responsibility to identify it. And the other thing is, I want you to take, I really do. I want you to take this national exam, not I'll hand you out one. If you get a passing grade, I'll hand you out a certificate from Victor Valley College that says you took basic arithmetic, okay? Which can maybe get you a cup of coffee somewhere. I don't know. But watch this. If you take a national certificate, okay, through the same people we have our phlebotomy students take their national certificate, you're nationally certified. That tells me more, okay? It tells me that you understand why you're doing what you're doing. And it's not an easy test. It really is not. And it's proctored. I took it. They made me take it. And I said, why? I'm a registered. Oh, no, you have to take it. And I'm going to tell you something. It was a couple of times I didn't know, where they were coming from. Like, here was one question I remember. Where does the spark originate? I'm going, the spark? Was somebody lighting a fire here? They're talking about, where does the electrostimulus begin? The SA node, right? Sinoatrial node, posterior wall right atrium, near the entrance of the superior vena cava. Okay, but you have to know more than, so you got to be able to answer these questions. All right. Guys, God bless you. Thank you for taking your time to learn this. Understand this. I'm going to take you through this. Whatever I need to do, I'm going to take you through this. Now, I want to do this Wednesday, if I can get it set up. If not, I'll send you an email, sometime Wednesday afternoon. I want to do Zoom for a short time. And here's why I want to do that, because I want you all gathered together somewhere in your house, not gathered together, social distancing. And I want you to ask questions that you don't know about. Okay, I read this, so what does this mean? Okay, because I want you to understand it, and I want to be available to you. So I want to do Zoom at least once a week. When? At 6 o'clock in the evening. For how long? Not very long. And I want to ask, okay, is there any questions that you have? And I want to guide you through this. All right? So Zoom is a great thing. It's a great learning tool, and we can do that. If, once again, I don't think we're going to make it, on Wednesday evening at 6 o'clock, then I'll call you. I'll tell you, okay, we're not going to be able to make today's appointment. Usually, I will make it. Guys, God bless. Have a nice evening. Have a good one. Anything comes up, you need questions or answers, call me. Especially on Zoom, Wednesday, 6 o'clock in the evening.